Hello and very good morning to all our delegates. I, Dr. Prachi Kiran, welcome you all to the annual refresher course of IMA Nasik, one and only unique conference, Sexicon 2022, wherein we promise you a great academic fest, words of wisdom from veterans, along with fun-filled wonderful evening. When we talk about sexual health, it's an ability to embrace and enjoy our sexuality throughout our lives. It's an important part of our physical, emotional health. Sexual health, when viewed affirmatively, requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experience free of coercion, discrimination, and violence. And when we talk about sexual health, the most important thing that comes to our mind is contraception. And to guide us more on it, we have with us Dr. Makarand Rane. He is coordinator between super specialists and obstetricians for women with medical disorders. He is MD Medicine and Fellow in Obstetric Medicine, the member of International Society of Obstetric Medicine, ISCCM, and many more. He is the first in Maharashtra to introduce the concept of obstetric medicine. Presently, he is running his own unit and is available for teleconsultations globally. He also has publications in the field of medical disorders in pregnancy. I request Dr. Makarand Rane to please guide us about contraception. Over to you, sir.
Good morning, everyone. Thank you, ma'am, for my introduction. And first of all, I'd like to thank IMA for giving me this opportunity in the early stage of my career. Today's topic is quite untouched topic. It's contraception, and the tagline given to me is quite comedy: "Make love, not babies." We are going to start the conference with this. The conference Sexicon is going to be good academic and topics are very interesting. Let's begin. We come from a healthy land, the land of India. We have been ruled by Britishers for almost 150 years, and most important reason for the local people from Britain to stay in India for so long is not the economics, but the healthy season, healthy land, and good interaction between people staying here. So we are part of this healthy land. Our lives are good, and we can have our healthy relations with each other. In our past history, we are seeing the Khajuraho temple. It is famous for its idols, having many different sexual positions and intimacy. While enjoying our heritage, this is what we have done to ourselves. In this healthy land with good opportunities, our population has exploded. We fall among second in the list of highest populations in world after China, and we are about to cross it. So we are going to be rank one, and it is not a good thing. There was somebody who took this matter seriously, and during emergency of 1970s, he made contraception compulsory, and this is what we have given. This is how we treated somebody who made contraception compulsory, and nobody is really very happy to talk about contraception. The master stroke we have given to society is this: the condom lending machine. You drop a coin and you'll be getting a condom. And this is our attempt to control our population and control the social issues that are related to population, economics, and other health issues. And we can see the result. It is a bike carrying a couple having, I can count 4 children in them, and a police person is there who is requesting them something. In our day-to-day life, like how much we are handy and known to the contraception. What our younger generation is trying to understand through television is this: it's a chocolate, a lollipop with different flavors. What I don't understand, what they are going to understand out of this. And another photograph is showing a balloon and in different shapes. And this is how we are promoting contraception openly, socially. Uh, I'm Dr. Makarand Rane. I am MD Medicine. I have done my fellowship in obstetric medicine. I deal with medical disorders in pregnancy. And like a common doubt, being a physician, what is my role talking about contraception? So my interception with contraception is just when a lady comes to me with some medical disorder and she has recently been married, I want to stabilize her, and after stabilization, I'm going to let her conceive. For that period, I have to use contraception for that lady or for that couple, and it has to be specific and suitable for that medical condition. But that is what theory says. In practical, the stories are different. Why this thought of contraception came to me. There are many childhood friends of mine. After getting admission in MBBS, they started calling me की भाऊ आज डेट है काय करू काहीतरी मदत कर. And I was like, something wrong is going on. That thought just continued in my mind. After a few years, I was about to finish my MBBS. I was in internship, and a few of my cousins started getting married. So from pharmacy background, from medical background, they started asking me similar questions like, की लग्न झालंय पण काहीतरी प्रॉपर मेथड सांग कारण की अजून 1-2 वर्ष तरी काही प्लॅन नाहीये. फॉर दॅट a short span of time, they needed a help in form of contraception. And nowadays, as most of my patients get attached to me for almost 9 months or more than that, and once she delivers and things are fine, they have a baby, and husband comes to me, like not many, but around 8 to 10 cases have occurred. Husband comes to me and asks की आता माझं झालंय आणि यानंतर नकोय किंवा यानंतर कमीत कमी 3 ते 4 वर्ष तरी आमचा प्लॅन नाहीये तर एक सुटेबल गायडन्स तुम्ही आम्हाला करावा. So these scenarios are there. Like really, in your life, how many times do you plan to have sex? Almost 99.99% you don't plan to have baby. You get intimate with your partner to have maybe only less than 0.001%. And that is the actual need of contraception in society, which nobody is thinking about. That is called as unmet need. That in society, every couple or every person needs contraception, and hardly anybody is aware of the availability of contraception, the ways they can be protected from getting pregnant, the ways they can continue their intimate life. About population, as I have shown few slides earlier about population explosion, in early 70s, government had brought तो या 3 birth wala norm, and that time population was not really very high, and within 10 years they realized no, population is going really growing at a rapid rate. In 1980s they brought a slogan called "Hum Do Hamare Do," and in this picture we can see a happy family with 2 children. But we all know that China has surpassed in reducing their net production of population significantly by making contraception compulsory and making their child norms very stringent. So family planning is a very important aspect of every couple, and it has to be considered immediately after getting married. What is family planning? It is a way of thinking and living that is adopted voluntarily upon basis of knowledge, attitude, and informed decisions by individuals and couples in order to promote a health and welfare of family, and thus contributes to social development of the society and relative to the nation. This is a baby who is proud of my working woman, of a working mom. So there are n number of like a huge percentage of working women in society, and family planning is an inevitable aspect of their life. What are the considered in family planning. It is to avoid unwanted birth, whatever the cause may be, to bring about wanted birth, to regulate intervals between pregnancies, to determine number of children in family, and to control time at which births occur in relation to age of parent. These all are significant points we need to understand, and it has to be implemented in our lives. And we all, being doctors, we are being sought forward by the society for guidance of such things. And whenever somebody seeks for help regarding this, these points need to be considered. Few points about PSM eligible couple. It is currently married couple wherein wife is between the reproductive age, that is 15 to 45 years, and target couple is those who have 2 to 3 children already. They are actual target couple who need to be considered. I'm not going to give a boring talk about PSM because last time we read about contraception was somewhere in a chapter of hormones in pharmacy, and few points in PSM. So I'm going like this talk is going to be oscillating between PSM and 50 Shades of Grey. I'll try to make it more interesting by doing this. For contraception availability in world and particularly in Indian government has provided a cafeteria approach. What is a cafeteria approach? Whenever you go to a cafe, you have a menu card. There is a long list of coffees available. You choose depending on your actual need. की तुम्हाला टाइम स्पेंड करायचा आहे, तुम्हाला तुमची झोप घालवायची आहे, की जस्ट टाइम स्पेंड करायचा आहे, की यू नीड टू हॅव अ गुड कन्व्हर्सेशन. Along with that, तुम्हाला अजून काही फूड ही रिक्वायर्ड आहे. That is a cafeteria, and we need government has actually provided a cafeteria approach for Indian population. We have a huge list of options of contraception available to us, and I'm sure most of us are not aware. Being doctors, we are not aware of all this. Forget about the general population, non-medical population, and we rather know that they are actually in need of knowledge for contraception. What are the characteristics of an ideal contraceptive? It should be effective, it should be safe, it has to be acceptable socially, it should be accessible and affordable, it should be easily available, and most important is it should be reversible. These are the characters. There is not a single method which is ideal for contraception because you cannot get all these characters in any one field. So we have to choose, like first we have to have knowledge about the experiences of contraception. The effectiveness of a method does not depend on the efficacy itself, but it is on the patient education and patient compliance. So we are at an end of responsibility to share them the right information, educate them properly, and make it sure that they are compliant. Knowledge of advantages and disadvantages of method is essential for the prescriber. That helps guide for the safest and most consistent with consumers' lifestyle. I won't be going in details of consumers' lifestyle, but yes, choices are there and we need to respect them according to their lifestyle. As there are a number of choices, the choice is never going to be simple as black and white. We have to personalize their lifestyle, their needs, their choices, and then give them proper prescription. Now, in short, we are going to touch few birth control methods. There are two major classifications. Few methods are reversible and few are irreversible. Barrier method is most commonly used and easy to use. Diaphragm or cervical cap, which has a failure rate of 17%. Sponges are there, which has failure rate of 14% in Nalibara and 27% in mothers. Male condom has failure rate of 13% and female condom has failure rate of 21%. This is how a condom is happy to protect you from getting pregnant. Spermicides are there, failure rate is almost 21%, and they cannot be used alone. They have to be used with some other method of barrier contraception. The options of spermicides are foams, creams, jellies, paste. Suppositories are there which need to be implanted inside, and soluble creams are there. The next method of reversible contraception is intrauterine contraception. levonorgestrel interference systems are there. Failure rate is really low, that is 0.1 to 0.4%. The examples commonly used and available in India are Mirena and progesterone. CU, there is copper T devices are there. Their failure rate is 0.8, and copper T is most commonly used in population, and it is safest for people having medical disorders in pregnancy. So I am going to discuss that later. Just like I want to know more, and how does it work? Is it is the insertion painful? Can it fall out on its own? How effective are IUDs really? And these are few questions, and we need to be prepared for such questions. Ideal candidate for contraception who has born at least one child, has no history of pelvic disease, has normal menstrual periods, who is willing to check IUD tail regularly, has access to follow-up and treatment of potential problems at earlier hospitals or in rural areas, at least followed by ASHA, is a monogamous in a monogamous relationship, because IUDs are not going to protect from sexually transmitted infections. Contraindications, we already know PA cervix, pelvic malignancies are there, and history of previous ectopic pregnancy, because ectopic pregnancy increases when IUD is inserted. Related contraindications are anemia, menorrhagia, woodland cervical discharge, unmotivated women, and women having fibroid, because that it is going to give rise to the size of fibroid. Those people need to be asked to seek medical help nearby if they have any kind of bleeding, vaginal bleeding, pelvic pain, pelvic infection, risk of uterine perforation has to be explained. If they have pregnancy, we need to take appropriate action. If there is ectopic pregnancy, again it gets a little complicated. If there is expulsion, they need to seek immediately to check for any local complication, infection, and the rate of failure of contraception is high if there is expulsion, and if there is any signs related to cancer. Next, we have hormonal methods. The options we have implant, injections or shots, and then oral pills and packets. Then hormonal vaginal. Oral pills are there, combined pills containing estrogen and progesterone. Progesterone only pills are there, postpartum pills, that is morning after pills. Once a month pills are also there, and male pills are still in research since many years, almost since 1960s they are being tried, but because of different issues they are not in market. Adverse effects that commonly need to be checked are cardiovascular effects, carcinogenicity because of high estrogen content, metabolic effects, liver disorders, lactational effects are there, ectopic pregnancies as we already saw, and fetal effects. If a patient is consuming the tablets and there is failure, and if she conceives, then we need to take appropriate action. Contraindications are CA and CHML, liver disease. Thromboembolism is a significant contraindication. Then congenital hyperlipidemia, abnormal bleeding, and a few relative contraindications are age more than 40, history of smoking or current smoker, hypertension, diabetic, kidney diseases, a known case of epilepsy on particular antiepileptics, and migraine, particularly with aura. Depot progesterone acetate. It is in dose of 150 mg intramuscularly, given to be given deep IM every 3 months. Suppression of evolution and unfavorable effects on endometrium, cervical mucus, and changes in fallopian tubes are the mechanism of action. They are lactation stage, and so they can be used immediately after birth of baby for spacing of the next pregnancy. Side effects are weight gain and irregular bleeding. Norgestrone enantate. It is available in 200 mg form. It to be given deep intramuscularly, and it has to be repeated every 2 months. And for these two, there can be availability of 2 weeks. The date can be missed by 1 or 2 weeks. And its mechanism of inhibition of ovulation. Sub-Q Provera. It is to be given subcutaneously. It is 104, a little lower dose than DMPA. It is given subcutaneously, and it has to be repeated after every 3 months. The issues regularly faced by these people we have already seen in 50 Shades of Grey that Anna and her gynecologist used to have frequent discussions, frequent visits. She was recommended Depo-Provera for contraception and along with mini pills, and she frequently used to forget that, and to prevent her from getting conceived, actor had to use something wrapped in a wrapper. Then we move on with combined injectables. Combined injectables have progestin plus estrogen. They are used in variable doses and variable forms are marketed. Intramuscular injections are there, and they have to be taken monthly. Side effects of these injectables are disrupted normal menstrual cycle, unpredictable bleeding, at times excessive bleeding, and the amenorrhea can be really confusing because if it is prolonged amenorrhea and with failure, then most of the things this can be missed, and that needs to be properly counseled to the patient, and that may warrant frequent ultrasonographies in case of amenorrhea, and it is reversible within 6 to 18 months, which is a good point about them. Contraindications are some cancer, abnormal uterine bleeding, hypertension, hypercholesterolemia, and thromboembolic events, and they have to be spaced in lactating mothers for 3 to 4 months after delivery. Then next option we have is subdermal implants. They are available in name of Norplant. They are not available in India easily. They need to be imported. It is levonorgestrel inserted subcutaneously below forearm or arm, and once inserted, they provide protection for almost 5 years. So there is a prolonged period of joy. And the only negative points are a minor surgical procedure is required, and the second is menstrual irregularities, as we already saw in IUD. Then the next point option we have are vaginal rings. Levonorgestrel containing rings are there. They have to be kept for 3 weeks, and they have to be removed prior to the next menstrual bleeding. Uh, it helps to reduce the loss of estrogen, which actually has major side effects. And the important aspect we have with them is immediate reversibility. We have patches, which are transdermal patches, which can be easily applied on back or shoulders. Efficacy is low in overweight patients, and they have to be avoided in patients more than 90 kg, and they really have lower doses of delivery. Fertility awareness methods are the ideal method which we can counsel to our friends, the calendar method, but in emotional events, failure is more common in this. I have kept this slide particularly blank for abstinence because abstinence we all do understand, but we all are blank how to do and how implement it actually, and whether to advise it to somebody, because everybody understands but difficult to use. And other methods are coitus interrupters and rhythm method. Lactational amenorrhea method, it is highly effective, but it is really temporary, and proper guidance has to be given to the couple, not only to mother, and immediate advice of barrier contraception has to be given after 2 months of delivery, because the first period that occurs after delivery is the first flow, and the cycle has started already 28 days prior to it. Emergency contraceptions, that is immediate insertion of copper IUD. It has to be inserted within 5 days of unprotected sex, and emergency contraceptive pills are there. They have to be given within 3 days of unprotected sex. These are the doses available. We already know, and they are available in market once a month pill. It is since many years. It is under trial. It is a long-acting estrogen, quinestol, and added with short-acting progesterone. It has high failure rate, and side effects of irregular bleeding remains along with it. Male pill, as I already said Vasipol is there. It is under trial since 1960s. It was used for almost 10 to 15 years in early 80s. But the side effects were male were getting azoospermic and 10% were not getting their sperm count back to normal. And it is not useful immediately. It has to be consumed for almost 4 to 6 months, and after that, the sperm count needs to be checked, and then assurance of sterility is there. And such a constraint in male population is really difficult to tackle. Now we'll go through permanent methods shortly. There are terminal methods. Female sterilization, that is tubal ligation, is there. Failure rate is only 0.5%, and it is sometimes reversible surgically. Such patients have started coming with laparoscopic field procedure. Male sterilization, which is vasectomy, failure rate is only 0.15%. It is very easy. Uh, it is to be done under local anesthesia. It is OPD procedure, but hardly not even 1% male population opts for this globally. If promoted and counseled properly, we can uh, reduce most of the confusions regarding male sterility. Conventional contraception, these are the ones which do not need to be used any active method at time of birth. Few issues are there. One is latex allergy. It is common with condoms, and male or female, anybody of them can suffer. To attain the family planning and population control and proper utilization of contraceptives for this intention, we need to have accessible services, affordable options, client-centered care, evidence-based techniques, effective communication and coordination with the suppliers and patients and the people who are going to proceed, and contraceptive security. Unmet need, as already I have already explained on this. It is high. It is actually seen in women of reproductive age starting from 15 to 24, because that is the population who is sexually active, who is getting married, and they are getting conceived. And though married, the spacing is very much important in such population. And rural people are more in need of contraceptive advices than urban population. And this is an important issue, contraception in adolescents, not in India, but Canadian government is at highest in taking care of contraception in adolescents. They have made contraception free for all adolescents, because issues they have is they are at the age of physiological maturation. 11% of all the global pregnancies happen in this adolescent population, and they are 100% risk pregnancy because most of them are not married. Though married, it is quite early, they don't want it, and they have to go ahead with some mode of termination because they are all undesired pregnancies, and they at times land up in illegal abortion, and then they face mortality or secondary sterility in form of morbidity. The options for adolescents are barrier methods. Condoms are preferred over diaphragms because diaphragm needs a proper way of utilization. Few are or an hour prior to the coitus, and which is really difficult at this population. The hormonal methods are there. They are most adequate as complete. They are completely reversible, and there are no hormonal side effects or no carcinogenic effects at this particular age. IODs are there, but they are particularly contraindicated for pelvic pain and infections. And once inserted, that girl or that young lady has to be counseled properly to visit nearest hospital in case of pelvic pain or infection, because that can be hazardous in a very short period of span. Though complications are there, it is related contraindication. Implantable IODs are preferred over the repeated abortion in that particular population. Spermicides are there, but they are not advisable as they do not protect from the transmission of infections. uh, for that population, particular they need to be counseled regarding combined contraception. Their combination of contraception is preferred as protection of infection is the failure rate really decreases by increasing efficacy. This was all about the methods of contraception. What are the other issues that we deal? Privacy. Like, people always call की आजूबाजूला कोणी आहे का नसेल त्यावेळेला मग फोन कर आणि then they start talking about this. Such a common issue and we need to make people aware to talk freely and openly and till the time they feel free we have to protect their privacy and there is this new concept. It is present in continent of North America and it is coming up in Europe. In India, there is only one center which is contraception clinic. It is recently opened in Apollo Clinic, Chennai. And actually, Europe or US is not the land where this is required. India is the land where it is most required, and particularly in rural area. Now I'll switch to a little bit of my topic, contraception for women having medical disorders. I won't be going more details. Ideally, all women should have a reproductive plan so as their pregnancies are intended and planned. This is a must for all women who have medical disorders. Because once diagnosed, they start their own treatment, they stabilize their disease. At some point of time, they get married. India has a social taboo about medical disorders is there. And if after like at time of marriage they don't reveal their treatment part or their medical disorder to their in-laws, they stop taking the treatment, and the disease is at unstable level or some critical level, and that is the point when they enter their first pregnancy, and creates a real challenge. So, familiarity with appropriate options of birth control is an integral part of their medical care. So, once diagnosed, so what is the right time to discuss regarding appropriate contraceptive methods for that particular girl or lady having that medical disorder as early as she is diagnosed? She may not start the treatment, she may come to you for follow-up or not, but definitely she is going to get married and she is going to conceive earlier because there is a fear in their mind because ती आजार आहे आणि खूप जास्त आजार खराब होण्याच्या आधी किंवा जास्त गोळ्या सुरू होण्याच्या आधी मला बाळ व्हायला हवं. So what we can counsel them till they opt for a proper method is abstinence, barrier for wisdom method, and if pregnancy is absolutely contraindicated. For example, WHO class 4 cardiac condition, some grade 4 renal conditions where she is going to land up in dialysis, or some vasculopathies related to diabetes. In that conditions, we have to immediately counsel their parents and opt for sterilization after proper consent. WHO has given elaborative medical eligibility criteria for contraceptive use. It was published in 2009. There is safety coding. Code 1 is for no restriction of use. Code 2 is for advantage of use that outweighs the risk of use. And code 3 is for risk outweighs the advantage of use. And code 4 is given for unacceptable for the health risk. COC is combined oral pills. P is for patch. R is for ring. CIC is combined oral contraceptive. POP is progesterone pills, and following things we already know. According to disease, they have given grading. I won't be going in details of the tables. They are quite a mess, and I'll be sharing this to you. So, particular reason of me sharing these tables to you is we all are doctors, and some point of time we deal with pregnant ladies, and when they come to you as first contact, I think it is our moral responsibility to make them aware for their pregnancy related issues of the disease and simultaneously to advise them appropriate contraceptive methods. By referring these tables, we can directly or for appropriate and suitable contraceptive method to them. These are rheumatic diseases with particular conditions. These are liver diseases with particular conditions with them. Neurological conditions are there with particular medicine. Cardiovascular diseases are there. Endocrine diseases are there. About endocrine diseases, goiter, about thyroid disorder, there is no contraindication. We can use any kind of medicine, and particularly hematological, as we all see in all these diseases. On the second last column, we can see it is the column of property. We can see one in all the rows in this table. Here, SLE with severe thrombocytopenia and patients on immunosuppression. Only these conditions have given code 2 for property. In this liver diseases, it is always 1 for the property table. In neurological diseases, it is always 1 for property table. In cardiovascular diseases, these valvular heart diseases with infective endocarditis cases, it is 2. Otherwise, it is 1 here also. In endocrine diseases, it is always 1 for property. So, among all these contraceptive methods, property seems to be the safest method of contraception. And I can say that we can blindly use property. It has its own side effects, but yes, in medical disorders, it is safe. Except for hematological diseases like deficiency, thalassemia, and sickle cell, property has been coded as 2, and other all are category 1. What to give a take-home message for this? Whenever we use a proper contraceptive method, even angels are there to protect us from the uncovered complications and from mishaps and morbidities that we may suffer or we may give to our patients. I thank you all for your patient listening, and I thank IMX for giving this opportunity. Thank you very much.